Okay, okay, okay. How many of us are insurers? Okay, okay, nice one, nice one. Okay, okay. All right, I'll be telling you something in the course of this program. But here to welcome us and to give us a recap of yesterday, what we did and what we didn't do, is our conference lead facilitator. Would you please make welcome Dr. Delanyo Dovlo.
Thank you. It's good that we are the same height, so we don't have to change. Good morning. What I would like to do is to take the next 5 or so minutes to run through a number of areas that I picked up during yesterday's sessions, and to again remind us of where we are here and how we want to proceed. Yesterday we had the opening ceremony. We did have, again, a reminder on the key objectives of this conference. That is to provide a platform for sharing lessons learned from experiences around the region, disseminate good practices, and contribute to institutional capacity development in relation to health financing. The idea was also to discuss health insurance and look at its role in advancing universal health coverage and health security. We did listen to a number of dignitaries, the Director General of the WHO, the National Health Insurance Authority Board Chair, the Minister of Health on behalf of His Excellency the Vice President. We've had a global overview provided by Matt Jawed. We had an African situation analysis of sorts by Professor Barasa. We've had the NHS story of Ghana from the National Health Insurance Authority. And then we spent the rest of the day listening to a variety of country experiences from quite a wide range of different countries. We had from Gabon, Mali, Senegal, Kenya, Rwanda, Namibia, Ethiopia, Nigeria. Did I skip any? Hopefully not. If I did, come by the break time for a cup of coffee. There are a number of issues and messages that started coming out of the discussions that we had yesterday. I hope I would have covered most of it, but I also hope if I didn't, you can remind me of areas that were mentioned but did not come up. I would not pretend to go into any detail or to do a thorough analysis of everything that was said here. But I would like us to go through as a reminder, recalling some of the things that we discussed, the following issues. First, there was quite a discussion in different elements of what we did yesterday around the context within which we are running this in Africa. We had low-income countries, we had lower middle-income countries, upper middle-income countries, and we discussed the issues around how these affected the health financing and insurance context. And some clarity around the fact that being higher income does not necessarily translate into better performance. We had countries of very different population sizes. We had Nigeria's 200 million thereabouts, and Namibia's presentation with their 2.5 million population, which somebody whispered to me, that looks like the little city across the road from here in terms of the population. And wondering if that makes it more manageable than if it were one of these larger, massive countries. But I guess they also have their issues of geography and so on, that placing. We understood that we are in countries with relatively high levels of poverty and also high levels of informal employment, informal labor populations, which makes it difficult for organizing collection of premiums and other ways of organizing health system. But we also had examples of what one might call means testing, being able to categorize populations and understand those that should be exempted from payment of premiums or those that special programs should be assigned to in order to alleviate their problems. This, of course, related to all the various issues of the social and economic and other determinants of health, some of which are entirely outside the health sector. There are major issues around equity and inequity, and about financial barriers, and about what are the vulnerabilities that we try to address, whether around gender, whether around pregnancy and maternity. But there's a host of other vulnerabilities that we need to think about in terms of how we make sure that universal health coverage is indeed universal, but not to certain. And there were issues around who has access to these things, whether it's a wealthier part of society or poorer elements in society. Then beyond the context is also the different sources of revenue and financing for health. We discussed the issue of social health insurance and how it relates to tax-based revenue. Excuse me. But clearly, there's still fairly high level of out-of-pocket payments in most of the countries that we discussed. Again, public government funding was, from about every presentation, still of major importance. And probably the majority of the total health expenditure came from there for most of the countries. How does that affect national health insurance schemes? Because there were questions around whether governments might want to reduce their investments in health if revenue is being raised through some of the means that were discussed. The other thing that struck me was generally, I think apart from Malawi also, low levels of external funding as part of the MILO for many of the countries. But the question remained, what is sustainable financing? How do we maintain this over the long period? There were issues of whether mandatory or voluntary approaches to insurance. We discussed the drivers of poor financial protection, and though maybe not to the depth that one would have wished, we did talk about the inefficiency challenges. Is the money being applied the way that we should to get more health out of our Naira, the last year of Kwacha, not to mention the cedi? And so, as we move on, the issue then becomes, in relation to UHC as well, what are the package issues, the beneficiary packages, and the disease burdens that we are dealing with? It is clear that there's a transition in our epidemiology from communicable to non-communicable diseases, that we need to be thinking about how to tackle the chronic diseases that are increasing in our region, including things like mental health, not much mentioned, but I think critically important. I think we celebrated World Mental Health Day a couple of days ago, and nobody's really talked about that one, which also struck me. And there were all sort of discussions around benefit packages, but also the exclusions and why we have those exclusions, and what it means for different populations if there are certain exclusions that cannot be covered within the package. And there were examples of different approaches to dealing with cancer, dealing with renal dialysis and things like that. For example, we heard from Gabon and a few other places around that. Part of the objective of this conference is to talk about health security. And there were mentions of the challenges in financing health security. maybe as we proceed today, we'll have a better opportunity to discuss that in some detail. But also there were whispers around the issue of health promotion and prevention. And how does our investment affect that? Particularly as we have a non-communicable disease challenge, and we need to invest in that in order to reduce the impact that would have in financing health services in the future. There are, of course, other challenges around other emergencies beyond normal health security ones, ambulance care, acute trauma emergencies, natural disasters, and the health impact of all those that we need to also think about. A lot of the discussions looked at universal health coverage, particularly the wonderful cube that we have, and indicating how we feel the different arms of that cube. Perhaps one of the challenges is whether, as we feel coverage here, coverage there, does it really result in better health? And so I hope we begin to look with some depth at what the outcomes are from these investments that we made. And that leads us into the issues of what is quality of the services, what is effective coverage, and what do countries need? And linked to that and mention in some aspects is the functionality of health systems. Are the health systems that we are investing the monies into functioning well? There was a slight mention of one thing that I thought was particularly important, but maybe we have not had enough time to delve into, which was the issue of public awareness, public knowledge, public engagement with the schemes, and also in generating public trust in raising money from them, but also whether it meets their particular demands for services. There was a lot of discussion around the institutional arrangements, the governance of these monies, the use of digitization and IT tools. There was a strong emphasis on decentralization as a way of generating efficiency and closer to people health financing. But there were also issues of public financial management issues and again linked to the efficiency things that I mentioned later. And as we mentioned about institutional capacities. Very important is the level of private sector engagement, which from many of the discussions were relatively small inputs in the discussions that we had, and whether this will grow. Perhaps let me end with one of the areas that came up often, but nobody really defined it to me, which is the issue of political will. What is political will? How do we measure it? How do we know if it's adequate? And I hope we can get more discussions around that. But another issue that had come up right from the beginning and through all the presentations has been, how do we measure all this? What are the right indicators that will take us along in terms of how we are performing? And on the Africa summary, where for 36 countries, maybe 4 have about 20% coverage, it's not really good performance for our region, and maybe only Rwanda and Ghana above a 50% coverage of insurance. And this means that a lot more needs to be done in the discussions around how we are going to raise the bar and to raise the coverage of financing, but also of the services that we have. There's been a number of innovations, but I hope we'll listen more and find out what people are doing differently in order to raise the stakes in financing health for UHC and health security. So that's my take on the discussions we had yesterday, and I hope some of it will stimulate the discussions we are going to have today. Thank you.
Ladies and gentlemen, that's a yeoman's job. A round of applause for Dr. Delano Dovlo. Indeed, talking about political will, it is proper that we have as our chairperson for today a man who is the Presidential Advisor on Health, having served with distinction as the Director General of the Ghana Health Service. Would you please make welcome for his remarks for today, Dr. Anthony Nsia Sarri.
Thank you very much, Jeffrey. I want to say first, good morning to all of you. And I can see the room is not as full as yesterday. Maybe because of the rains, people are coming. We've already spent about 30 minutes, and we were supposed to start at 8:30. So all what I'll say is that I accept to be the chairperson for this function. I'll give my closing remarks at the end of it all, so that we go quickly into action. I'll say thank you very much for electing me as a chairperson for this morning. I'll sit quietly, listen to you, and then learn from my brother, my classmate, and my friend, Dela, to see where the political will be, so that we know how to measure ourselves and then assess what we are doing if we have given enough political will. So once again, I say welcome to all of you, especially those who came outside from all over Africa. And as it was said yesterday, I think this is the first time that we are meeting as a continent to discuss this very, very important issue, financing health in Africa. So on that note, I'll say thank you once again, and I'll call the MC to take over and call the panel to start the discussion. Thank you.
Thank you very much, our chairperson, and clearly we can tell that our professional colleague has now gained the weight of the politician. And so quickly, let me invite to take their places here members of the panel, a representative from Uganda, Cameroon, Senegal, the School of Public Health, University of Ghana, that's Professor Patricia Akwinogo, and the Director Research, Policy Monitoring and Evaluation, NHIA, Mr. Francis Asensu-Boedi. A round of applause as they come. Moderating this panel, we're delighted to have from the Department of Economics, KNUST, Professor Sister Eugenia Ampofo. In 45 minutes, they will deliberate, and in 15 minutes, they would revert to us, the audience, for Q&A. A quick roll call. We have Uganda here. Uganda is not here. Cameroon. Okay. Senegal. School of Public Health. Okay. And then NHIA. Okay. So who's left? Cameroon is not here. Oh, that's Cameroon. Okay. So I think the only missing is Uganda. Okay. I believe later on Uganda will join. Professor Sister, we're all yours.
Thank you. Good morning, colleagues, brothers and sisters. Good morning. We are happy to be here, and according to what we are the topic for discussion today, we are looking at the challenges and linkages in healthcare financing, or financing UHC, and health security. Normally when we look at health security, the focus is on the country's ability to prevent and respond to health threats. And not too long ago, we had our pandemic, and our population is always faced with all kinds of health threats. And to be able to ensure that we do so, we talk a lot about achieving universal health coverage. And under that, we want to make sure that people have access to the essential services and they are able to do so regardless of their ability to pay. And we know that many countries in Africa have made a lot of strides in trying to achieve universal health coverage. And it's so important to all of us, and it's part of the SDGs. And so here today we are going to listen to what is happening in the various countries. We have only 4 countries. We have Ghana, we have the been passed. So we'll start with you, Madame Senegal.
Merci beaucoup. Moi, je suis Madame Diao Tchanegay. I wait for you. Okay. Donc, je suis Madame Diao Tchanegay. Je suis la coordonnatrice de la cellule d'économie de la santé.
Hear.
You cannot hear.
Is it working?
Please,
Can you hear? Oh, okay.
can you hear me?
No.
Je suis Madame Diao Tchanegay. Je suis la coordonnatrice. Je suis Madame Diao Tchanegay. Je suis la coordonnatrice de la cellule d'économie de la santé au ministère de la Santé et de l'Action sociale. Donc, c'est une cellule qui a été mise en place donc, juste après la validation de la stratégie nationale de financement pour tendre vers la couverture sanitaire universelle. Juste pour dire que le Sénégal, à travers son Excellence le Président de la République, a lancé le programme de couverture sanitaire universelle en 2013. Et ce programme va être mis en place par l'Agence de la couverture maladie universelle qui a été créée en 2015. Et en 2017, nous avons lancé l'élaboration de la stratégie nationale de financement qui a comme orientation stratégique 4. Et les 3 premières orientations stratégiques sont alignées aux 3 piliers de la couverture sanitaire universelle avec une 4e qui porte sur le financement de la santé qui est le socle aujourd'hui pour nous permettre d'atteindre la couverture sanitaire universelle. Beaucoup de choses ont été déjà réalisées dans cette stratégie nationale de financement puisque nous l'avons élaborée de façon participative et inclusive. Parce que la santé n'est pas simplement du domaine médical, donc il y a d'autres déterminants qui entrent en jeu. Raison pour laquelle aujourd'hui, cet aspect de déterminant de la santé est important aujourd'hui si on veut vraiment atteindre la couverture sanitaire universelle. Donc, nous avons besoin de faire la promotion de la santé à travers les autres départements comme l'éducation nationale, comme les forces armées qui doivent appuyer le secteur de la santé, comme l'environnement et comme l'assainissement. Aujourd'hui, nous avons réalisé beaucoup de choses dans la couverture sanitaire universelle à travers l'assurance maladie. Comme vous le savez, au Sénégal, nous avons plusieurs régimes de financement. Nous avons le régime des agents de l'État. Nous avons aussi le régime des agents privés avec l'Institut de prévoyance maladie. Nous avons aussi les régimes de l'assurance volontaire avec les mutuelles de santé. Nous avons aussi les régimes volontaires avec le secteur privé, ce qu'on appelle les sociétés d'assurance privée. Nous avons aussi
private insurance as well. And then there's assistance, health insurance assistance, and this refers to people who cannot care for themselves. The government attends to their health needs through under the UHC program, and so over there we take care of children who are under 5. And then women who have undergone cesareans are covered over there, and then old and elderly people, and then people who are receiving grants from the states, and then those who are holding, that's the disabled, they are also under this health mutual. We have encountered a number of difficulties under this. Today our challenge is to have just one warehouse for data. The national UHC agency needs to supervise all the regions. So, in order for all the regions to function, they need to talk to one another. We need to have one data point, and then we should be able to do better targeting and then improve funding. This is important for the success of universal health coverage. On the supply side, a lot of things have been done. With the onset of the COVID-19 pandemic, the Ministry of Health has drafted a sectorial investment plan in order to build quality infrastructure and then hire quality and qualified personnel. The demand side is doing its work, but then if we do not have quality infrastructure and then qualified personnel, then that will have an effect on demand. A lot of things have been done at the emergency units. The regulatory frameworks have been reviewed, and many things are being done there. And so these are the few points that I have to say about what Senegal has done in universal health coverage. Thank you.
Just briefly, how did you deal with the pandemic? COVID-19.
Pour la pandémie à COVID-19, comme le Sénégal a un comité national de gestion des épidémies. En même temps aussi, nous avons le centre des opérations.
And then we have an operations center for health emergencies. So we really work to handle this COVID-19 pandemic today. From 2017 to 2019, we had just one treatment room at our hospital, but then today, in all the regions, we have pandemic treatment centers in all the 14 regions. We have also acquired more ambulances, and that's helped us to manage the pandemic. I believe that Senegal is a model in pandemic management. That is why the president insisted that we would need a sectorial investment plan so that we would make the sector more resilient and sustainable. Okay, thank you very much. I'm Dr. Mintop Anesi Desiree, the National Coordinator of the UHC Technical Unit of Cameroon. Coming back to the first question, the last question on the pandemic management, I'd like to say that in 2020, Cameroon, like all other countries, went through this epidemic. What we did was, first of all, we did general mobilization at the strategic
Sur le plan
level.
technique, on a eu un centre des opérations des urgences qui s'est mis en place avec un SI et nous avons immédiatement renforcé nos capacités sur le plan du laboratoire, ce qui fait que et nous avons déconcentré, décentralisé la prise en charge dans les 10 régions au niveau des hôpitaux de district et au niveau des centres de santé. Ce qui nous a permis effectivement d'avoir une meilleure prise en charge
for us to better attend to patients
la morbidité, mais
and then
également
reduce
la
the
mortalité.
morbidity and mortality.
Il faut dire que par rapport à cette pandémie, on a eu beaucoup de leçons apprises et on a capitalisé les acquis de cette pandémie qui nous permettent aujourd'hui de renforcer efficacement notre système de santé. Au niveau des laboratoires, par exemple, on a vu notre laboratoire national de santé publique prendre beaucoup d'envergure, où on est capable de faire toute une batterie de prestations en termes d'examen de laboratoire. On est capable de faire des séquençages, on est capable de pouvoir faire plein de choses qu'on ne pouvait pas faire par le passé. On a également sur le plan technique des acquis en termes d'infrastructure, on a des acquis en termes de logistique. qui aujourd'hui nous ont permis de pouvoir améliorer. Il faut quand même dire que la Covid nous a permis aussi de revoir au niveau national la stratégie globale avec l'appui de l'OMS et de tous les autres partenaires. On a revu nos stratégies dans nos stratégies sectorielles, on s'est réadapté et la Covid nous a montré quand même que malgré beaucoup d'avancées que nous avons eu, le système restait encore fragile. Il était important d'axer effectivement sur la promotion, sur la prévention, sur le pilotage et beaucoup plus sur la coordination des acteurs qui sont multisectoriels. Et je pense que ce sont des actifs que nous avons pu avoir pendant la Covid qui nous ont permis effectivement dans la même veine de pouvoir mettre en place continuer le chemin progressif de la couverture santé universelle qui était déjà en 2017, il faut le dire, une instruction du chef de l'État lorsqu'il s'adressait à la nation au 31 décembre de l'année 2017 qui instruisait déjà au gouvernement la mise en place progressive de la couverture santé universelle. Et ces réflexions ont été entamées depuis 6 ans et le 12 avril 2023, le Cameroun a mis en place, a lancé officiellement la couverture santé universelle. Alors ici, il faut préciser qu'on a une contrainte, c'est que le Cameroun ne s'est pas encore doté d'une loi pour la couverture santé universelle et c'est l'un de nos challenges. Mais néanmoins, on a pu lancer la couverture santé universelle face à tous les constats et pour permettre au pays de mieux expérimenter les procédures, c'est-à-dire tout ce qui rentre dans l'enrôlement, dans la capacité des populations à pouvoir y adhérer et même les mécanismes, à savoir les gestions des prestations pour un renforcement stratégique. Et c'est ce qui a été fait et aujourd'hui, on a donné la priorité à la femme enceinte, à l'enfant de moins de 5 ans, à et les dialyses. Donc, sur le plan global, notre panier de soins, il est promotionnel, il est préventif et également il est curatif avec ces pathologies que je viens de dire. Il faut également préciser que dans ce panier, le financement de la couverture santé universelle dans cette phase 1 est essentiellement assuré par l'État du Cameroun et ses partenaires. Si vous pouvez bien le constater, pour cette phase 1, le pays a mis en commun toutes les interventions qui par le passé étaient disparates pour faciliter l'accès aux soins, à savoir la prise en charge du paludisme chez les enfants de 0 à 5 ans, qu'ils soient graves ou qu'ils soient simples. Et aujourd'hui, avec la couverture santé universelle, on a brisé la barrière de la consultation chez les enfants de 0 à 5 ans. Elle est totalement gratuite et remboursée dans le cadre de la couverture santé universelle. La dialyse est également remboursée et les femmes enceintes et les enfants ont la possibilité d'être pris en charge aujourd'hui dans ce qu'on a appelé l'intervention de la CSU, qui est le chèque santé, qui consiste à payer sur le franc CFA et à pouvoir bénéficier des prestations pendant la grossesse jusqu'à 42 jours de vie pour l'enfant, y compris les complications et tout ce qui pourrait survenir pendant la grossesse. Donc voilà un peu globalement comment sur le plan technique on se déploie. On a mis sur pied une organisation qui va d'une cellule technique au niveau national, au niveau régional, on a des unités régionales et on a un tiers payant qui est le fonds régional. Il faut dire que 50% de nos interventions sont financées par l'État et 50% par les partenaires, notamment au niveau des intrants et au niveau des organisationnels. Donc voilà un peu globalement comment est-ce que nous se déploie. Les challenges sont nombreux, il y a la multisécurité, il y a la coordination, il y a les intrants et le plan législatif, il y a la loi qui viendra consacrer non seulement la contribution obligatoire, c'est-à-dire résoudre le problème de financement, mais aussi va nous permettre de pouvoir migrer vers une agence qui permettra de gérer
Thank you very much. Can we now move to Uganda? What approach is Uganda using to be able to achieve UHC? And how did you deal with the pandemic?
Thank you so much. Mwalimu Ali, I am a principal health planner from the Department of Finance, Policy and Planning, Minister of Health Uganda. I am also the desk officer for the National Health Insurance Scheme Design. We also host the UHC office in terms of preparation on behalf of partners in Uganda. Yes, Uganda has a free healthcare system, so services are supposed to be fully funded by tax revenue, so you don't have to pay anything when you go for services. So that makes our life very easy, although we're also trying to see that we have prepayment schemes. We have a UHC roadmap, 10-year roadmap that details what we should do in terms of our journey to UHC. And in it, we try to get all the pillars. One of the things that we plan to make sure that we strengthen primary health care as a pillar for us to improve. Uganda has 2 levels of service delivery. A decentralized level that is PHC, from community to level 5, a district health hospital, and then we have the national level that is under Ministry of Health, that is regional and national referral hospitals. So this, in part of design, guarantees that everybody should access services. Although while services are free, we have also discovered that there is very high out-of-pocket expenditure, which means there is a challenge in terms of access. Yes, our indicators show that we are actually doing fairly well, but that doesn't mean the system is okay, simply because if we have free health services and they are quite expensive to access, then there is a challenge. So that points to a number of things that we've done under the UHC1, is to make sure that we strengthen the primary health care and the referral system by increasing infrastructure. Right now we have over 90% or so population living within 5-kilometer radius of a health facility, but that is not equally distributed. There are some districts that have up to 10 kilometers to travel, but even then, even with some of them are hard to reach, and therefore we find these challenges of access, even if we have that kind of coverage. Therefore, we are doing targeted infrastructure development and equipment. This is a plan we have for over 5 years to make sure that those hard to reach areas are equipped with facilities, staffing, and medicine. To also have a challenge of course, perception. We know that people perceive public services as being poor, whether that is real or not, but we also know that there's some truth in it. So what we've done is to make sure that we focus on quality improvement initiatives, and we now set up a department of patient safety, protection, standards and accreditation that looks at making sure that each facility has a quality component in their delivery of service in terms of making sure that they are focused on patients. So we've done very well in terms of supply side by investing in infrastructure, making sure there is supplies, although not very adequate, but we try to supplement from partners, but that has also been increasing. Equipment, staffing, we've just restructured our staffing structure, and now it is almost 3 times what we had, simply because we're addressing the various disease conditions that have been persistent over time. But that has also tripled the wage bill. But that is good news, because now the focus will be at finance to find the money. But for us, we've done our work, and the wish of all stakeholders, I think the staff are happy to make sure that we address that. For the demand side is what we are looking at, and one of the things that we are doing is to make sure that we mainstream results-based financing in the PHC, where initially we've been providing money to the facilities in terms of input, not related to outputs, but now 30% of that money is going to come from results-based financing. One key component is you'll get this money after we've done a survey to realize whether the quality of care as perceived by patients is okay, and that will also add on to what you get. So that's an attempt to make sure that we do improve access at the lower level. Another one is a strong participation by community by creating a national community health strategy that focuses on inputs from community rather than focusing on the facility. Lastly, I think there's been a debate on how essential is our package, and we're currently looking at the NCDs as well. So our benefit package has just been updated from the Uganda National Minimum Health Package to the Essential Healthcare Package in line with the universal health coverage aspirations. So all these are tied up to one thing: how do we finance this? I told you that the financial risk protection is a challenge on our country simply because of one, we may be having inadequate financing, but two, the way we purchase the services as a challenge, and three, how do we work with different sectors? And I think this is where we're focusing on the multi-sectoral approach to make sure that services are accessed by all, irrespective of their income or where they stay. Thank you.
Can you add just one sentence on how you dealt with the pandemic?
Yes, Uganda is
one
prone,
sentence.
Uganda is prone pandemics, but what we've done is we have a national strategy that has been mainstreamed at different levels. So pandemics are mainstreamed. So every level of service delivery has planned for it, but also have the highest level office of the Prime Minister. They've also provided for an emergency fund that will supplement the financing, and that I think so far has done very well. Thank you.
Thank you very much. We now move to Ghana. Dr. Akwongo.
Okay, so thank you very much. I'm coming from the academia point of view, and I would like to say that most of the work that we've done so far has actually been in collaboration with the National Health Insurance when it comes to the secondary data analysis, and some of the work that we've also done in terms of primary health, primary data collection has also been in collaboration with the National Health Insurance. And we are also happy that now they've come up with an agenda that will even make it a lot easier for us to access data and to also work with them. Now, going back to how has Ghana really, what have we done to be able to achieve or look forward to achieving the UHC? And I think yesterday we heard a lot about the success story of Ghana, where Ghana has now become a learning platform for many African countries because of our national health insurance. And if we look at from 2003 up to now, we can see a lot more has been done to actually improve what coverage. But as Prof. Barasa mentioned yesterday, in terms of the 2021 DHL analysis, we are at 50. And from most of the internal work that we've done, we know the coverage is more than 50. But when you are looking at averages, we are talking of 50. What have we done? Because we have a very generous package where we are covering 95% of the diseases. And then in addition to that, we have a free maternal health care policy that provides access to care for all maternal and child health care services. And then in addition to that, we have also a generous package for those who are poor, the core poor. So now they've ceded that to the livelihood empowerment program, where they are actually selecting those who can benefit from this package. In addition to that, the platform, the National Health Insurance over the years have also tried to address some of the challenges that the scheme faces. One of them, looking at how best we can get people to enroll in a much easier manner than some of the challenges that they were facing. So we've moved from the manual, now they've gone to mobile renewal and so on. So we can say that looking at the response of the scheme, both from the supply side and demand side, we've been progressing steadily. And then in addition to that, we heard yesterday that we are it's mainly tax-based, because you can see that in terms of the informal sector, we don't have much people coming in to enroll on the scheme, so we are heavily relying on our taxes, and in addition to that, we are also relying on the formal sector. So these are some of the areas that we actually need to look at how best we can actually work in terms of when it comes to efficiency and equity. And then coming to that, we'll say that if you look at the primary health care, for us, UHC is equal to primary health care. And I think that has been the slogan, and that is the music that is being played everywhere, that if we really look at in terms of efficiency, our primary health care needs to be strengthened. And we did a study actually looking at what is happening at the primary health care level. And interestingly, everyone would like to access care closest to them. So if they want to access closest to them, why are people not accessing services closer to them? One of the major issues is the quality of care. So you look at the CHIPS level, you look at the health center level, and then people are bypassing all these ones to go to the hospital, not because they don't want to use the health centers and the CHIPS. And interestingly, when we did the analysis to look at where people are actually delivering, at Dabraka Polyclinic, for instance, we had close to 80% of people who use the ANC there, but 70% of them would deliver at a Rich Hospital. Why? Because everybody is expecting that the quality of care, when it comes to delivery, will be much better at Rich. But if they can do their comprehensive ANC care at Dabraka Polyclinic, they should be able to also, and most of these deliveries were also vaginal delivery. They were not even CS, where we say that we need what, especially. So I think this is where we need to look at when it comes to quality of care. And then in addition to that, most of the reasons why they were moving to other facilities were also because of drugs. People, they were paying out of pocket for drugs and even consultation. And as high as 41% were paying for at the CHIPS level, and 43% at the health center level, and 53% at the hospital level. And when we talk of the hospital, most of these was actually the district hospitals. So there's still a lot that we can do to actually move quicker into achieving universal health coverage. So I would say that we've done a lot, we've done so well, but there's still a lot for us to do, and especially in areas of equity and in areas of efficiency. If we can do more efforts in terms of how much we can reduce inefficiencies by moving our services closer to those who need it, I think we'll do a lot better. Then in terms of equity, as we are seeing, also the same people who are on the ground are actually the ones who are not really able to access the quality services. So that is one. And then maybe to add on the pandemic. So with the pandemic, we did a study trying to look at the COVID-19 response team, as well as some of the frontline workers and so on. And interestingly, most of the stakeholders said that we were very successful with the pandemic because there was intersectoral collaboration, but also a very strong political will. They mentioned that what made this successful was because at every meeting, the president was always the chair. And so he, as for instance, the Director General said there was no way he could have invited other directors from other ministries to come to meeting, they will come. But because the president was always present, so that is where the strong political will is so important. He was always present at these meetings, and because of that, there was no way a sector minister or a sector director would refuse to come to that meeting. And whatever resources that they were supposed to put forward for the pandemic, they did that. So for them, that is actually the key. And then in addition to that, they talked about the fact that our health system is really well structured from the chiefs level all the way to the tertiary level. And so even with that, the routine services, it reduced a little bit, but by July, October, when we did the analysis, they had all picked up because immunizations were going from home to home, and most of the basic services were still being carried out. So for political will and a well-structured system, we're able to manage our pandemic. Thank you.
Thank you very much. Now that we've heard about the efforts that the different countries are making, let's now look at financing in general. And when we are talking about healthcare financing, we first would like to know what we are trying to finance. What are we purchasing? The benefit package. Dr. Sensu-Boadi. In Ghana, we have our benefit package. But very often, the focus is on curative care. We don't talk a lot about preventive care. But yesterday, we heard that diseases such as non-communicable diseases that are so closely linked with our lifestyle is on the rise. Do you think preventive care should receive enough attention to help us achieve universal health coverage?
Thank you very much, Prof. Good morning. Yes, it will be my simple answer that preventive care is very, very important if we are to help achieve better health outcomes in terms of the non-communicable diseases. The challenge there is the how. Knowing that the preventive healthcare is very important, but how do you do it such that we prevent abuse? And when you say preventive, what exactly are we asking that people go to, for them to be checked? For example, if you want to introduce screening, what type of screening for which cohort of people is the main issue? I remember there have been discussions since 2007 for NHIS to cover preventive health care. But when you ask what type of preventive health care are we supposed to cover and who should benefit from it and how many times, that becomes an issue. So yes, we need to go into preventive, but we need to know what the type of preventive services that are required for which group of people. For example, we know that if women between I think from the ages of 30 upwards are screened regularly for cervical cancer, and those who may be found to be positive could be treated and the outcomes may be very well more cost effective than the patient getting the cancer before being treated. However, how many times are we supposed to screen the individual? And then from which age do we do that? We need to look into those things and then structure them so that if we want to do annual screening, we know if an individual gets up at a particular point in time, goes to a facility, we know exactly what will be done. When we get to know the package as to what to be done, then we can cost it and know how to fund such a system.
Thank you very much. I know health promotion is also a form of preventive care. And yeah. Madam from Senegal. I know Senegal, you also have a benefit package. And for a good benefit package, it should be sensitive to the needs of the population. So we say that the services should be essential. And those services should be cost effective. and affordable. Can you describe the kind of benefit package you have and how affordable are they to ensure that people are able to have access to them in Senegal? Are you with me?
Voilà, merci beaucoup. Donc, pour le paquet de services qui est offert par rapport aux différents régimes, donc le paquet est différent d'un régime à un autre. Aujourd'hui, par rapport au régime d'assistance sociale, nous avons plusieurs bénéficiaires. Donc, pour les enfants de 0,5 ans, donc il y a un paquet qui a été défini. Et quelle que soit la structure que reçoit l'enfant, le paquet est défini et le montant est fixé. Et c'est à partir de ce montant-là qu'on doit rembourser la structure. C'est la même chose avec
that reimburse. It is the same for the package on cesarean sections and then dialysis in hospitals. At the health facilities that receive the patients, the packages are set over there, and then the packages are validated with the support of the National Health Insurance Agency and the medical board.
Aux aspects de prévention qui sont très importants
when it comes to preventive care.
That's
very important. I spoke about this in the national strategy. We looked at the health determinants. So today, we focused more on prevention and realize that there's been an increase in cases of non-communicable diseases. And so when it comes to preventive care, we have vaccination against cervical cancer, and for girls aged between 9 and 14. In October, we organized awareness campaigns on breast cancer and cervical cancer.
Avec la direction qui s'occupe de l'information et de l'éducation sanitaire au niveau
Health Information and Education Services Center at the Ministry of Health. We worked with them on these awareness campaigns on non-communicable diseases.
Qui a été mis en place par la direction de la lutte contre les maladies pour demander à ce que
the Directorate for Disease Control has also sent out calls for healthy foods in order for people to practice healthy diets in order to reduce these cases of non-communicable disease and also live healthy lives, be active and in sports. And so this is what we have done. I don't know if I've responded to your question.
Yeah, thank you very much. Yes, you have. The Cameroon. We know that to be able to come up with a good benefit package, you itemize some of the services that you cover. Now, to be able to come up with these essential services, we need stakeholder engagement. Now, it's important that we have intersectorial engagement as well as engagement with the public. In the Cameroon, we know that there is this high mistrust of government. To what extent is that affecting or impeding the government's ability to be able to come up with a good benefit package that reflects the needs of the population?
Ok, merci pour cette question. Il faut dire que sur le plan du paquet de soins qui a été identifié pour la première phase de la couverture santé universelle que nous avons appelée CSU phase 1, c'est un paquet qui répond effectivement aux besoins des populations parce que nous on a fait une étude, on est en train de mener une étude actuarielle qui a déjà fait la première partie qui a été présentée, à savoir l'évaluation des soins pertinents Et effectivement, le panier de soins que nous avons actuellement figure parmi ce panier de soins catégorisés dans parmi les 6 premières préoccupations en matière de santé des populations. Donc, à ce niveau, on va dire que le besoin, il est déjà confirmé, il n'est pas contesté. Maintenant, pour cette première phase, il faut le dire, nous, on a lancé il y a 6 mois seulement, mais au jour d'aujourd'hui, on est pratiquement à 2 millions de personnes qui sont enrôlées, qui sont enregistrées, et on est à 1 200 000 personnes, 213 000 personnes qui bénéficient effectivement du panier de soins dans le cadre de la couverture santé universelle, qui sont enrôlés, qui ont leur carte, qui bénéficient des soins et dont les factures sont remboursées par l'État. Donc c'est pour dire que la question de l'adhésion ne se pose pas. Les populations sont effectivement en phase avec l'initiative qui a été lancée par le gouvernement. On a, comme je l'ai indiqué, on a des contraintes qui sont, comme vous le savez tous, lorsque l'État est le principal bailleur, bien que sur le plan budgétaire, on ait une allocation, mais il n'est pas toujours évident de mobiliser cette ressource, parce que l'État, c'est le trésor, c'est la caisse commune, et il y a beaucoup d'autres choses. Et je pense qu'à ce niveau également, l'État a pris une résolution, parce que l'État a opté pour le cadre pour la couverture santé universelle de créer un compte séquestre qui consiste à une convention.
So there was an agreement between the central bank and then the government, and then an amount systematically deducted
mensuellement au remboursement des prestations liées à la couverture santé universelle. Donc je pense que la question de l'adhésion, de la confiance, ça si après 6 mois on est à 2 millions de personnes enregistrées.
Well, the issue of mistrust is there, but then if you have this number of people who are enrolled, then I think it's not so much. We still have non-communicable diseases which are still a challenge. We need to guide these people. They are needy. But then I'd also like to emphasize that in the system that we have set up, we are looking more at prevention and promotion. We believe that if we do not do this, then the bill for caring for these diseases would be astronomical. No matter the amounts that the state or private individuals contribute, we cannot pay the bill for the actual diseases. That's why we are focused more on prevention. And through UHC, even if the law comes with compulsory contributions, we still want to focus on prevention and promotion. We are also working on decentralization. We have done skill transfer, and so we are working with all these stakeholders to have an effective system. There's also the issue of multi-sectoriality, which is not a simple one. Health is not just the bread and butter or the Ministry of Health. We need to bring in other ministries, and so we have brought on board the other ministries. And then there's also a civil society coalition for UHC. About 80% of the civil society groups have put themselves together, and so this shows that there's a buzz around healthcare. Thank you.
On to revenue contribution because of time. I didn't say to go to. So Uganda, you said that you rely on tax revenue. Wow, we have 5 minutes. Uganda, you rely on tax revenue. So please let your responses be as brief as possible. Okay, you rely on tax revenue. how progressive is it? Because the reason why I'm asking is that you have very good infrastructure for healthcare. You have a lot of facilities, but very low utilization rates. If you take antenatal, for example, only 37% of pregnant women are able to make the 4 visits of antenatal, even though you have health facility everywhere. Why do you have such low access rate or low utilization rate, even though the facilities are there?
Thank you so much. Yes, ideally, tax funded should be progressive in that, of course, those who have more money will be paid through taxes. But yes, I think the challenges go beyond financing. I think most things that we are suffering from are maybe systems issues. And one of them is, what's the cost of accessing services from the supply side? I think that's where it is. We have ambulances, but in most cases, we need to fill them for you to be maybe taken if you need an ambulance. But also if you want to access a facility, you need to get a border. So that means you need to get some money from your pockets. I think that simply explains. 2, I think there's also, I did mention the issue of perception by the community. If they don't trust the facilities, they always think twice before they go. But another issue is that the time the services are provided is always delayed. So sometimes people have to wait for a very long time because staff have to move from different places, and the opening time is not convenient to the community. I think that's why, apart from financing, those are some of the things that we need to sort out. Thank you.
Yeah, thank you very much. The next question goes to all. When we are talking about universal health coverage, it's very important that the sources of funding are locally, the revenue are locally generated. That ensures sustainability. However, when we look at the services, especially medicines, African countries depend a lot on imported medicines. So how can we claim to be very serious about achieving universal health coverage when we are so dependent on external supply of our essential medicines? Just very briefly, so that everybody gets the chance.
Okay, so if we currently look at how the National Health Insurance pays for medicines, we know that we are using the fee for service, and we know that fee for service is also one of the most inefficient way of actually reimbursing, because it can lead to over utilization of pharmaceuticals. So that even adds to the trouble that we are looking at, that we are importing, and then it can also lead to overutilization of. So we need to actually encourage local production. And I think Ghana, we are already into the right direction. Now that we have established our Institute of Vaccines, and we are going to have local manufacturing, I'm sure this is already a very good pipeline that would encourage more production of pharmaceuticals within the country. But we also know the Ghanaian mentality. Anything that is within the country is not really appreciated. So I think with the promotion bit has to also come in, that it is not what we get from outside that is always the best. So I think that's also one of the things that the National Health Insurance Authority has been struggling with. Even people don't want generic drugs, they want branded drugs. And I think one of the countries yesterday gave an example where they are now branding their local products so that it will become appealing to the clients. So maybe we could also think about that. How can we brand our local products in such a way that we can also improve upon and then reduce the cost of pharmaceuticals to the scheme?
Dr. Sensubodi, I will ask a different question. One of the important agents in achieving universal health coverage is providers. They play a very important role. To what extent have they helped the Ghanaian National Health Insurance to achieve universal health coverage, to be able to improve coverage, to reduce out-of-pocket payments?
It has been very tough with them because as was shown yesterday, though Ghana is doing very well with the population coverage and our benefit package being very generous, still we are very high out-of-pocket payment, and mostly the out-of-pocket payments are for medicines. So providers, they are well scattered around the country helping to deliver the services, but when it comes to policies that are to be implemented to ensure that the patients get the services without paying, there are issues in there that we need to look at. But it may not be entirely the fault of the providers. It may be multi-stakeholder issue. For example, framework contracting arrangement was instituted by the ministry to help reduce the cost of medicines. Companies bid to win to supply the medications. After winning the bid, they refused to supply, and rather they refused to supply to the central medical stores for them to give to providers, but rather would like to go and do business directly with the providers. And it creates a whole lot of issues that I think policymakers will have to look at and solve, so that the end user will get a benefit without having to make out-of-pocket payment there. Providers have been helpful, but we have caveats.
Thank you so much. Now I'm going to ask each one of you to give your closing remarks.
Prof. Sister, is it possible to go to the audience and then after they do their closing remarks? Thank you very much. And so we have 15 minutes to engage you, our audience. Please raise your hand. You have mics on your table. Identify yourselves. Shoot straight to your comment, your suggestion, and let's take from here. Yes, sir. You have a mic on your table. Please make your comment or question very short, straight to the point.
Yeah, for sure. I'll be very short. Victor Uteganya from WHO Angola. So I would just like to know, maybe this is for all the panel members. We have talked about the prevention and promotion component that some of the countries are offering, or almost all. I would like to know what are the measures that they have in place that actually they can measure the effectiveness.
Operator, your mic. Sorry.
Yeah, thank you. So my question is, we have heard of the prevention and promotion measures that are also are part of the benefit package, or of the measures that the countries are taking. So I would like to know, what are the ways that they measure so that they can see whether the promotion and preventive activities or strategies that they have, actually they have impact on the health interventions that the countries are doing. So maybe if you have, maybe cases, uterus cancer cases, maybe you had 20, and maybe today, because of the promotion and activities that have been taking places, maybe today they reduced to 5. So maybe just to know, how do you measure that? Thank you.
Let's keep the questions, comments straight to the point so they can get the gist.
Thank you very much. There was a discussion around financing health security. And indeed, a number of experiences coming from different countries. What we have seen over time is a situation where countries are rather reactive to shocks in the emergencies in the health sector. Can we have some examples of countries that are more proactive in terms of sustainable frameworks or sustainable approaches to financing health security in the country in terms of preparedness, the response, and also recovery in these countries?
We shall take 2 more. Yes, sir. Would you want to try your mic, please? Don't worry.
Thank you very much. I'm Reverend Kingsley Amon from Asante Mary Foundation for Africa, Peace and Development. I wish to take this opportunity to tax ourselves. This is a reality. We have to face the reality, to tax our own selves, to come out with programs and policies that will help us sustainably achieve the SDGs. Thank you very much.
Hello, is this Yari? Yeah, Asante Mary Foundation. Please check their tax record. Last question, please.
Merci beaucoup. Merci beaucoup. Donc, j'avais deux questions. La première est adressée au Sénégal. Elle a parlé du lancement de la CSU en 2013. Est-ce qu'il y a une loi sur la CSU? Et de deux, est-ce que l'assurance maladie est obligatoire? La seconde question est destinée à tous les panélistes, en fait. Moi, en fait, avec tous ces régimes d'assurance maladie, est-ce qu'il y a en aval des mesures par rapport à l'évaluation, en tout cas par rapport à la performance, par rapport à la qualité de l'offre de service, et surtout par rapport à l'utilisation des services? En quoi ces régimes d'assurance ont impacté la qualité de l'offre et l'utilisation des services, peut-être en un ou deux chiffres? Merci beaucoup.
Merci. Ma question s'adresse à tous les panélistes. Je voudrais savoir quel a été le positionnement de l'assurance maladie dans vos pays respectifs pendant la pandémie de Covid-19. Est-elle intervenue en premier, en second, en support au ministère ou pas? Cette question est importante parce qu'on sait que l'un des principes de l'assurance maladie, c'est effectivement de ne pas être en première ligne ou de ne pas intervenir en situation d'épidémie ou de pandémie. Alors je voudrais savoir, je sais qu'il y avait des pressions politiques, il y avait des urgences à prendre en compte. Comment vos systèmes d'assurance se sont comportés? Merci.
Madam Moderator, 5 interventions. It's you and the panel.
Thank you very much. So we'll start with the first question. For the sake of time, we may not be able to ask everybody to answer the question. So we'll start with the first one about the effectiveness. If there is any experience in any country regarding the effectiveness of preventive care, maybe the Cameroon, if you'll be able to answer that.
Ok, merci beaucoup pour cette première question.
Very much for this first question.
Déjà, il faut savoir que la prévention et la promotion.
It's important to note that prevention and promotion are like the foundation.
On la voit, on l'évalue,
they are the foundation, they are the foundation stones. But we have some indicators which make it possible for us to assess our activities and see the progress that we are making, and then magically changing that from maybe like 50 cases to 2 cases would take time. I just like to say that there are indicators that make it possible for us to do that. In Cameroon, for example, for assessment purposes, we have indicators of promotion and then prevention in the various health districts and then in the various health facilities. These indicators are bought and then they make it possible for us to assess the activities that are being conducted over there. So when we go there with the demographic surveys, we can see if there has been regressions or progress. And then we have short-term indicators that we can make use of, but then we cannot make use of that to have predict the kind of impact that we're talking about. Thank you.
Next question will go to Senegal. So the question says that when it comes to the pandemic, the responses that we received were more reactive, what countries did to respond to the pandemic. But is there any proactive, action or efforts made to deal with such cases, like preparedness for such events or such emergencies? For the second question.
Voilà. Merci beaucoup pour la question. Donc pour
Thank you for the questions for Senegal. I think during the COVID-19 pandemic, I think that the coordination was multisectorial. The reason for which we have results which are very interesting ones, because it's only the Ministry of Health that was dealing with this pandemic, that UNICEF and other technical and financial partners, civil society, and territorial divisions as well, and we work together now to have good results. With regard to infrastructure, we've also increased the infrastructure, which are very well equipped. The health centers are well equipped to help us to be able to take care of COVID-19 cases. And to answer to the question of my humanitarian friend who wants to know with regards to a launching of the UHC in 2016. Today we have a law for the UHC, and because the law on the table and in this process we are waiting for the adoption of this law for the universal health coverage, and for health insurance that is compulsory, as has been done by Rwanda, but up to now Senegal has not yet acted on this, but we want it to be compulsory. We are trying to work on it in order to have health insurance very in an intelligent and smart way. So each time that we want to know the blood group of people, and the same way we want to ask people who would want to go to a health center, who want to have documents, and when you want to have them to produce their cards. I guess that's what we're going to do for the whole of Senegal, and that is why we are working to make this compulsory, and that is for in order to achieve UHC, we should go this way, and that's why it is important today that the countries that have not yet had this compulsory health insurance to think about it and do the necessary benchmarking in other countries that have succeeded, and we're going to work alongside them in order to have the UHC in their countries as well.
The third question is more of a comment. Uganda, you can respond to that. That African countries or Africans should be more self-reliant when it comes to efforts that we make to achieve universal health coverage, rather than depending on external support. What do you have to say about that?
Thank you so much. Yes, we have the wishes and also we have the reality. But I think from my point of view is two things. One, self-reliance is determined by the ability. There's a willingness but ability to do that. Our economies determine how much we can do. So yes, you may want to replace the foreign financing, but your economy is collapsing, so that cannot help. So one thing that we need to make sure that we have stronger economies. Whoever does that, we don't know. But two, of course, political will does miracles. Even if you have very limited resources, you can always prioritize what you want. So I think if we can address these two, we can be able to address what is the challenge we have of foreign dependence. Thank you.
Okay, so it's like we have to keep working at it until we get there. Dr. Akongo, The next question is on how our effort to achieve UHC has affected the quality of care in the various countries. So you can look at Ghana.
Okay, so we are implementing our national health insurance. And so as we are all aware, when it comes to national health insurance, especially those who have been insured, and even those who are even paying out of pocket, there's been evidence that the quality of care, a recent study that was done puts it around 60% that people are satisfied with the quality of care. But the problem has to do with people moving from the lower level to the hospital level. So people will bypass the CHIPS compound, they'll bypass the health center, and they'll go to the hospital. And so at that point, they will say that about 60%, the quality of care is about 60% satisfactory. So, but at the lower level, people don't seem to see there's good quality of care. Not really because it's just because the infrastructure is not there. We don't have the human resource, we don't have the logistics, and we don't have what what has to be there at those lower levels to actually improve quality of care. So I think recently the Ghana Health Service is partnering with a number of organizations to implement the network of practice. And that network of practice is actually supposed to support improved quality at the health center level, as well as the CHIPS level, and also for any referral purposes, so that they can get experts and consultants to be able to support the management of cases. So we are hoping that maybe with the implementation of the network of practice, we should see better quality of care. Thank you.
Dr. Sensubodi, thank you very much. Dr. Akongo. The last question is, how has UHC helped us, or how did it help us during the pandemic?
Yeah, thank you. Because people knew they could access care using those who have been enrolled onto the NHIS, since they knew that they could have treatment when needed, they were assured. During the pandemic, people were still accessing the facilities, especially those with chronic conditions who were predisposed to the COVID. They were accessing the facilities to be sure that their health were maintained for them. So our effort towards the universal health coverage in that sense, I think, helped the patients who felt they would be at risk because they had the preconditions that people thought that they were high risk. Yeah, so we have data to show that people were still accessing health care for those conditions like hypertension, diabetes, and other things. So it helped. For COVID, Ghana is actually acclaimed to be one of the best countries that managed it because of the task force that the president set up, which he chaired himself, and also the regular updates that were being given and reassuring Ghanaians as to the measures that were being put in place in fighting the pandemic. Because really the COVID was all about fear. Because all of us didn't know how it was going to end. Nobody knew who was going to survive and what was going to happen there. So being given reassurances as to measures being put in place to ensure that we were all safe, that helped us to survive.
Thank you so much. I think we'll now have our closing remarks. Just very briefly, 2 minutes per panelist. So starting with you, Dr. Sensubodi, since you have the mic.
Okay. Like I actually commented on Nigeria's effort yesterday, that whatever policy that we are discussing and trying to put in place, we must ensure that we put ourselves at the center, because we all use the services that we are planning for implementation. If we do that, then we will realize that whatever needs to be done to ensure that our
we know capitation hasn't worked, but it doesn't mean that it has. We can always go back to the drawing line. We look at how we can efficiently promote our primary health care to ensure that efficiency and equity can be achieved, because these are actually the drivers towards achieving universal health coverage. Thank you.
Thank you so much. I think the key takeaway is that UHC is not cheap. It's quite expensive, so we need to be aware of that. 2, we know we have political support, but I think we need more political action. 3, you also need strong technical teams to provide evidence for the politicians, but also to be able to take decisions objectively. But lastly is that I think we need to keep on reforming, not only financing, but also the whole of government system. Because you may have very good policies in the Ministry of Health, but Ministry of Transport and Finance is an obstacle. So we need to look at the overall issue if we want to achieve universal health coverage. Thank you.
Ok, merci beaucoup. Un mot de fin, tout un
My last two words, I'd like to thank you, Ghana, for this initiative that has enabled us for the first time for African countries to think about health financing in Africa, and that requires that UHSC is a priority for all African governments. That's why it's important for us to meet together to think about that. I think we can fund this universal health coverage when we evaluate the contribution of partners, so that our health systems, we already know that we have some deficiencies at the national level, and these are things that we need to discuss at the fora, so that we can share our experiences. I want to say that the preparation of emergencies that I'm inviting all countries to take these initiatives of the World Bank and to which, and these programs to which Cameroon has accepted to do, and then working other countries to follow this path. And we hope that UHC can be done, and it's a reality. We have already started, and we are on the right path, and now we should be able to meet regularly to talk about that. Thank you. Well, thank you for the invitation for Ghana, and we want to say that UHC, it is an ideal thing, and that today we should to put in place multisectoral committees. It is a matter that we should resolve, and for Senegal we have challenges to face as regard to the funding of the UHC, regards to the direct payment or out-of-pocket payment, and we want to take that away, and we have about 46%. We're on the right path. That's why we should continue to reduce this out-of-pocket payment and get to compulsory health and insurance, and that's what we're going to give the necessary help to the population.
Various countries, the challenges that they are facing, the efforts that they are making to improve the situation, and all have agreed that UHC is achievable. It's not here yet. Nobody is there yet. Some have made more strides than others, but there is always hope. Every country here has shown that there is hope. With more efforts, we'll be able to achieve it together. Thank you all for listening and for being interested in what they had to share. Thank you very much.
Ladies and gentlemen, a round of applause for our amazing panelists and the moderator. Thank you for lending us your great insights and your expertise. Joining us this morning, we're honored to have the Director General of the Ghana Health Service. Make welcome Dr. Patrick Kuma-Boakye. Thank you very much for joining us. We're exceedingly glad to receive also a health advisor at the FCDO, Madame Uzwamwaka Gilpin. Thank you very much, ma'am. Help me welcome the CEO of the Consumer Protection Agency of Ghana, Mr. Kofi Kapito. Thank you very much. And so if you're joining us live in person at the La Palm Beach Hotel or online, we welcome you to day 2 of this regional conference on financing universal health coverage. We're in the second day and we're in the first plenary of that day. Just gone by, we've had highlights on challenges, linkages, and lessons of experiences on health financing in achieving UHC and health safety. This leads us to a very important conversation which will feature experts from the WHO and other bodies. But allow me the pleasure of inviting a country that was conspicuously missing from yesterday's presentation. They've joined us today. Ladies and gentlemen, for 15 minutes, let's hear the lessons from Benin. A round of applause for them. Three, 4. Do you want to hold or I should put it here for you? I'm not getting part of it.
Thank you. Good morning, everybody. Bonjour tout le monde. Je vais parler le français. Hier, je n'ai pas pu être parmi vous dans la journée pour pouvoir passer la présentation du Bénin. Nous sommes dans la même veine que vous, en train de faire des marches à petits pas pour aller vers la couverture sanitaire universelle. Et, diapositive. OK, please show me. Et donc, ce que le Bénin est en train de faire actuellement prend en compte les 3 dimensions de la couverture sanitaire universelle. Donc, ma présentation va faire focus sur ce que nous faisons pour améliorer la qualité des soins et l'accès aux services de santé à tous les citoyens, toutes les personnes qui résident au Bénin. Ce que nous faisons pour assurer une prévention, une promotion de la santé, c'est revenu longuement dans les débats. Et puis enfin, nous allons faire un petit résumé sur le mécanisme qui est en train d'être mis en place pour l'assurance maladie universelle. Et donc, vous savez que le Bénin c'est le plus beau pays de l'Afrique. C'est un petit pays de 114 000 km² qui, depuis 2019, est classé comme un pays à ressources intermédiaires, mais qui, malgré les efforts qui sont en train d'être faits pour améliorer la qualité des soins et surtout l'accès aux services de santé, partage avec beaucoup d'autres pays des insuffisances sur ce qui concerne la performance du système de santé. C'est ça qui fait que lorsque le gouvernement du président Talon est venu en 2016, la première décision qui a été prise est de faire un état des lieux au niveau du système de santé pour pouvoir identifier les insuffisances clés sur lesquelles les leviers d'action devraient être définis pour pouvoir permettre à ce qu'on puisse rendre performant le système de santé et améliorer l'accès aux services de santé. Et nous avons constaté, après cet état des lieux, qu'il y avait une insuffisance en infrastructures et équipements de santé adéquats, une insuffisance
equipment and the poor management of human resources and then also does not allow the people to have access to help and we also, the governance of the health system is also a part of the problems that have been observed. And with this inventory, we have been able to understand a lot of health evacuation which have not been very functional, with a lot of resources that have been spent in order to ensure that the elite of the society get good delivery, and they do not do this to the detriment of the poor people, and for the others they can die, and we are having the best of all. So that is why we wanted to put in place a health system that will going to increase sustainably the well-being of the people in order to strengthen health quality and put in place health structures that would give specialized service and delivery to the people. So the ambition of Benin today, if we could compare our health system to aeronautics, we can leave the primitive airplanes that were invented a century ago and moving towards the supersonic planes. So there's a clear change that we are trying to put in place with regard to reforms, legislative reforms, which are helping us to put in place laws that define the framework of a health system, how to go up towards a better performance, and also also the regulation of health exercise, and also taking good care of health persons, and public hygiene laws, pharmaceutical laws that are going to help to put in place a necessary framework for health, and also to set up institutional reforms and authority of regulation of a health system. And today the President of the Republic that controls all of these, and especially the health sector, there has been very sterling performances that have been done in this area. That's why we're working hard to improve the quality of health in the health services. With regard to the institutions, the authority for regulation of the center has been set up with the responsibility of seeing to the regulation of health and the access of health to all citizens of Benin, and that has always been discussed every time, and that has been discussed here from yesterday. And for these authorities to also to work on questions which are very pertinent to the health of the people, and that's also in the policies, especially strategies that are being taken at the institutional level for the regulation of authorities of the structure that is also leading to accreditation. We want to do that up to 2025. All personnel in the health sector must be accredited, no matter your level, and without accreditation you cannot work. And especially for health services, public and private must be certified before they can also offer health services. We have national boards on primary health, and these are boards that have we are responsible for the standards, and these are the people who produce the necessary policies in this area. There are agencies that are there to operate and put in place strategic measures and in the health system in order to ensure health quality. We have an organization that helps to train health resources in the health sector to be able to give excellent health delivery. And the most important thing of the health and the good health, the quality of that the people need, what we need to put in place in order for the people to benefit for good health delivery. We also want to create specialized hospitals. We are centralizing this in order to have assistant mission at the local level to train the people locally to also provide high level delivery. So we're also putting in place specific services in partnership with Belgium, France, United States, and other countries. We have a cardiac surgery center which has been there for 2 years that has helped to operate people for certain pathologies which might have perhaps been sent elsewhere for operations. These centers these people are now having access to these services which hitherto they were not able to have access to. And we have genital poor centers also, which are also in operation. We have others that are in operation and which are being developed in certain special areas. So in the area of Benin, we are not only setting up this program that enables to train and to transfer competence at the local level or at the national level, but we are putting emphasis on the development of infrastructure. Today we are constructing hospitals of the latest of the latest forms. We are doing this in order to increase quality of health delivery. We have the National Center in Calavi, which is going to be soon open in 2024. We are about 85% construction of this hospital, which is going to be a specialized hospital with 440 beds, and this hospital is going to enable us to offer to have emergency centers for cardiology and also for heart surgery and other things, and so that these are going to be high-level specialities for which the simple diseases were not treated. So we are working to strengthen quality health in the country, and also to reduce reference to other places, and to help the citizens to have access to good quality health, in order to reduce the privilege that other people have. For now, we are constructing this specialized hospital, which is almost finished. It's going to be one of the best hospitals of the sub-region. In addition to this, in this landscape, we can talk about the three hospital complexes. We have the teaching hospitals, which are also being built, are going to be in addition to what we already have in place, and that's going to help us to reduce inequalities of access to. We are also developing programs for health, and these programs are new national policies, health policies, with the objective of to providing health, community health services to people for curative and promotion, which are also helping to guarantee the creation of necessary centers to take care of community health difficulties. So throughout the country, we are trying to deploy in the communities 14,000 health facilities with health personnel who could go from house to house and give health attention to people who need that, and go to the various households in the various communities and help them in their health predicaments. We also have the funding and innovative financing for the first year. We have partners that are helping us. We are going to support us for $140 million for the first year. We are mobilizing domestic resources, so that from the 7th year we should be able to finance totally this program from our own resources. We also have, in order to end it, we have set up a social protection policy, which is also holistic in nature. We are started with with insurance policy in order to revamp capital for us to be able to go on ahead to provide essential services to our people. We are now going towards a generalization of health to people, and for health assurance has also been taken into consideration, and laws necessary are being adopted in order that by the end of this year health insurance will be compulsory in Benin. And so the basket that in which this is going to be done is so wide, so that all infections, trauma, and all others, including fistula, and especially chronic diseases, and especially diabetes, are also going to be treated. We have done a costing for that, and then we would like to be able to work in order to guarantee the sustainability of this, so that all citizens are able to subscribe to this, and will be also supported by the employers, that 80% participation, with the employer himself contributing 20%. We have other measures, other additional measures. We have put in place a new mechanism to be able to have credit cards to people, in order for people to have access to dialysis treatment. We also to be able to application of this,